Hello all, I'm Dusan Nikolic, and this is a bonus lecture for phoneticians and for many of my students who expressed a wish to become speech-language pathologists or therapists. This will be hopefully an informative and brief lecture on how speech-language pathology relates to phonetics, the study of production and perception of speech. And with this lecture, I'm only touching upon a fragment of what speech pathologists and phoneticians would need to learn about. Of course, I'm a linguist, and I come from that perspective. And there is a wonderful course on SLP by Alexandra Zhrimiak, um, uh, link 337, which some of you might be taking as well. So you can learn about it in that course. This is also a nice lecture for the public, right? For the general public, where I will be introducing the relation between speech language pathology and phonetics. Um, so I will be touching upon both of these sciences. In 341, we talked about how to articulatorily describe speech sounds, and we mentioned several dimensions. So I would like to start with that. First of all, there are consonant dimensions that we talked about. For example, if you have two consonants such as t and y, you might have an airstream mechanism with which you are producing these two. Of course, airstream mechanisms explore how the air flows in general, and in this case, how the air flows from the lungs through the trachea, passing the glottis, larynx, pharynx, and entering into your vocal tract, and through your vocal tract into the atmosphere. So for these two sounds, we're using what we call pulmonic egressive, meaning that we are exhaling while producing these two sounds. Yeah, this is the first dimension. The second dimension will be phonation type, whether vocal folds are vibrating or not. As simple as that. So we have what we call vocal folds, which we will see later, and these vocal folds can be vibrating because of the air movement, or they can be open and not vibrating, in which case they are produce voiceless sounds. But if they are vibrating, we are producing what we call voiced sounds. Then we have place of articulation, meaning or denoting the place where our articulators meet each other. In this case, with the sound t, the tip of the tongue is meeting the alveolar ridge, and that's why we call this sound alveolar. With respect to y, the body of the tongue is meeting the palate of or the roof of the mouth, and that's why we call this sound palatal. Next one is aperture. Oops. So aperture is, okay, it doesn't cooperate with me, but the aperture is basically the openness, right? Or the degree of constriction, if you like it. So to what extent we constrict our vocal tract in order to produce certain sounds. For example, for the t sound, we're completely stopping the airflow from coming out at one point with our the tip of our tongue, right? For the y, we are not actually stopping the airflow completely, but we are producing the y by having our body of the tongue coming close to the palate, or to the roof of our mouth, and making an approximant, what we call approximant, because of the approximation of these two articulators, the body of the tongue and the palate. Then we have a retroflexion, whereby the t is non-retroflex and y is a non-retroflex. For example, r would be a retroflex sound, in which we curl up our tongue to the back, and the tip of the tongue is meeting the postalveolar ridge of the palate, which we will talk about in a second. So the sixth dimension with which we describe consonants is the nasality. With respect to the nasality speaks about whether the airflow is moving through the nose or not. most of the sounds in English are oral sounds, meaning that they're not nasal, and when they're oral, it means that the airflow is not moving through the nose. For n, m, and engma in English, the air is moving through the nose by lowering the velum and allowing it to pass through the nose. And finally, laterality. Laterality is the seventh dimension that we talked about. We are placing our tongue into the center of our mouth, this allowing the air to go to the center for lateral sounds, such as l or l or l, right? But for central sounds, we are allowing air to go through the center, and t and t and y are both central sounds. T and y are both oral sounds and non-retroflex in this respect. These four dimensions are sometimes called manner of articulation. Actually, more often they're known as manner of articulation. So I will just write it like this: a manner of articulation, and you will probably know to what I'm referring to or what I'm speaking about. I'm speaking about the way we constrict our articulators, the way we are moving our articulators in order to shape and mold different speech sounds. Right. These were the consonant dimensions, the dimensions or the descriptions, descriptive tags that we are using to describe the articulation of certain consonants. We have vowel dimensions as well. Vowel articulations can be characterized along four dimensions. These are height. Vowels can be high, mid, and low, or open, right? They can be open like ah, they can be closed like e, and they can be high like e, whereby the tongue is higher than it would be for ah, for example, right? Where the tongue is lower. And we are talking about the tongue body in this case. We have front and back, whereby the tongue body is either front, central, or back. For E, it's front or fronter than it would be for ah. For E, it's fronter than it would be for oo, right? For oo, it would be back. For E as well, it's fronter than it would be for, let's say, o, right? And these are the this dimension is concerned with the tongue body or where it is placed. Then we had two tongue dimensions, and we will have now perhaps one lip dimension, or the roundedness of the lips. So if you have rounded lips, such as oo, o, right, then you are making a rounded vowel. Most of the vowels in English are unrounded, such as e, a, e, and so on and so forth. And finally, in terms of tenseness or the effort with which we are producing these vowels, we have tense and lax, and they can be, for example, e is a tense vowel, a is a tense vowel, oo is a tense vowel, and lax vowels are those vowels that are produced more centrally, such as e, u, right? And these are lax vowels. So tenseness refers to the effort with which we are producing vowels, in short, right? All right, now that we know how to explain or how to describe, it's a better word, certain vowels and consonants, we can take a look at our articulators. So this is the anatomy lesson number 1. The principal parts of the lower surface of the vocal tract are the following: lip, tip, blade, front, center, back, root of the tongue. So this is a tongue, and this part here is epiglottis. With all of these, we can make certain sounds. I wouldn't, maybe it's an overstretch to have so many divisions of the tongue, but tip, blade for sure, then body of the tongue, then back of the tongue maybe, and root, right? That's how I would divide it up. And the lower lip is the one lip that moves mostly, although the upper lip can move as well. As I'm speaking, you can see my lips movement as well. So both lips are pretty movable, right? Pretty active articulators, and we call these below active articulators. Epiglottis also closes and opens. Epiglottis, or its primary function, is to not allow food or prevent food from entering your trachea, your lungs, and preventing you from dying in this way. So it's a very important organ, right? This is a velum here. It can lower in order for the air to go through the nasal cavity, or through the nose. That's how we produce nasal sounds. It can also be active, but not as active as a tongue, of course. Then anatomy lesson number 2, we have the upper surface of the vocal tract, whereby we have an upper lip, an upper teeth, hard palate, alveolar ridge, soft palate or velum, uvula, the little or uvula, the little dangling thing in the back of your throat, and the pharynx wall, which are all considered passive articulators, because the tongue is actually hitting those targets. These can be referred to as targets, and that's why we know, okay, if the tongue is hitting the alveolar ridge, then we are talking about the alveolar sound. If the tongue is hitting the hard palate, we're talking about the palatal sound, and so on and so forth. That's how we describe the place of articulation. Right. Okay, so we've learned something about, and we've learned that the most important or the principal components of the vocal tract that are responsible for producing certain sounds, right? We have the sound, the tip of the tongue is hitting the alveolar ridge right here, so it's just moving up very fast and hitting the alveolar ridge. Yeah, we had the body of the tongue hitting, maybe, or not actually hitting, but being approximated to the palate, and then the airflow can go through this approximately narrow channel, right, in order to produce E. With vowels, for example, E, there is no closure of the articulators, no obstruction in that sense, no complete obstruction, but we have certain movement of the tongue. For example, for E, the tongue would move up, let's say here, right? E, for U, the tongue would move further back, right here somewhere, right? And for A as well, further back and low, right? It will lower a little bit. So these are all relative terms in when we talk about vowels relative to each other, and that's important to understand. All right. Now, there are four, as I said, there are four primary active articulators in speech. Articulators we can move around: the lips, the lower jaw or mandible, the tongue, and the velum. These numbers here to the right describe the speed with which these are moving, actually. The tongue is the winner, of course. The speed of the tongue is huge. The tip of the tongue and the blade of the tongue are moving with 7.2 to 9.6, I think, meters per second or something like that. It should be meters per second. And the back of the tongue is moving much slower, right? Because it's much bulkier, it's heavier than the tip of the tongue, which is quite active. And this also testifies to what we will be mentioning, maybe this, we will definitely be mentioning in this class, that there are more coronal sounds in languages of the world, the more sounds that are made with the tip of the tongue and blade of the tongue than the back of the tongue, right? Because of its capacity to move very fast and to produce a range of sounds. The pharynx can also be constricted to some extent, but we won't be talking about it because it's the most passive out of all. There are some muscles here that can be constricted, but to make certain sounds. but we are still moving the tongue or the root of the tongue to make pharyngeal sounds or gutturals. Call them what you will. And a very important note, lips can be raised and lowered faster than they can be protruded or rounded. For example, you can raise them like ba 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 ba, very fast, in which case the jaw is also moving. But in order to round them, you need some kind of tenseness, right? More energy, more effort. So this takes more time, such as ooh, right? All right. So we now have the toolkit, the toolbox, something that we can work with, and these were the active and passive articulators. Now we understand how to produce certain sounds, right? And this was just a summary of what we have discussed in 341 in phonetics. If you want to find out more, yeah, shoot me an email or just read something more about it, right? I can give you some resources. Another articulator, I can maybe call it like that, or I can call them like that, are the vocal folds. Vocal folds produce sounds as well, right? We can just vibrate vocal folds or vocalize or do something with them by, for example, producing sounds like such as or right? It's still some kind of a sound, but most of the activity is happening at the vocal folds. They are either open, whereby we are producing voiceless sounds, or they are closed, but not closed entirely, tightly closed. They are, folded together, right? They are brought together, and because they are light tissue, right? They are light, really light tissue. They are being moved by this air, right? By this air that is moving through the trachea and from the lungs to the trachea, and the air pressure differences are moving the vocal folds up and down very, very fast. And vocal folds are tissue that is being lightly moved and fluttering in a way, as if they are the wings of a bird. In this way, we can produce a variety of sounds, and this is important because we can control vocal folds independently from the rest of our articulators, such as the tongue. For example, we can produce words such as, for example, low, in low sound, low, and we can produce words such as low in a high sound. For example, low, right? So you can control them independently from what is going on afterwards or in the vocal tract. All right. Now, so we have vocal folds, and sometimes to investigate the activity of vocal folds, we will do what is called laryngoscopy. Laryngoscopy is a technique for investigating, mainly used by physicians, for investigating the state of our vocal folds. Sometimes vocal folds can be in a poor state. That is, they can be damaged due to the certain kind of illnesses, for example, tumor, or they can be just damaged because you overuse them. Vocalists often experience this, and singers. And we want to investigate in which state they are. So what we do is we have this fiber optics cable, at the end of which we have a small camera, and we insert this cable through the nose or nasal cavity, and we insert it that deep enough in order to look at the vocal folds from above, right? And that's how we would see what's happening with our vocal folds and how they are in which state they are, right? By using the laryngoscopy and this, or fibroscopy. Sometimes they call it fibroscopy because we are inserting an optic fiber into patient's nose. And if you thought that a nasal swab for COVID testing is unpleasant, you should try this one for sure. Right. Okay, so the morals of the story, number one, I have morals of the story number two at the end, but the morals of this story are the following. These are not abstract dimensions that we talked about. These are the articulators that move and make certain gestures. So we have certain articulators. We give instructions to those articulators from the brain in which way they need to move. The motoric movements come from the instructions from the human CPU or the brain, right? And I told you this. And this is just a photo of a person where there is a disconnect between the brain and the articulator, right? Between the instruction and the articulator. And this is just an example of what kind of challenge certain individuals, or what kind of challenges certain individuals may have. And now we are entering the realm of speech language pathology, right? If there is any kind of disconnect, and in this case it's just an illustration of the disconnect related to where to place your tongue, people who use language, or children who acquire language, need to be aware of the dimensions to produce speech. And speech language pathologists, of course, need to know about the dimensions and the ways articulators move in order to help those individuals produce speech, if they can, of course. And there are so many strategies to do this. Now, as I said, we are entering the realm of speech language pathology, but what happens when you are producing speech is that you're conceptualizing, and this is just a plastic illustration of what might happen in stages. So when you're producing speech, you're first conceptualizing, you're encoding the language, right? You're encoding the message, then you're planning what to do with your articulators, and then you're executing this and then self-monitoring. Well, this was good, I should continue, the communication is successful, or the communication is not successful. For example, I might say able instead of table, and then make this correction, right? These three are concerned, we are concerned with we are concerned with all of these stages, but with these three particularly and to greatest extent. So although this diagram is a kind of a flow chart, information in the model does not always pass in one direction from higher to lower levels. It is possible for lower levels to influence higher levels, right? The reason why speakers might chew a gum, for example, and produce intelligible speech is because the conditions under which motor execution have changed, right? So this leads to adjustments in motor planning. So we have a lot of interaction here. It's not in one direction. So this is just as I said, a plastic, really basic illustration of the flow chart or of the stages of producing speech. Now, I'd like to start with dysarthria, right? Dysarthria is a muscle weakness due to neurological injuries. Now we are heading straight towards certain challenges that affect individuals and that speech language pathologists should know about, right? So dysarthria is a muscle weakness due to neurological injury. Muscles become weak or difficult to control. The injury includes the injury to central and peripheral nervous system, but also to cranial nerves. And the cranial nerves are those nerves inside of your cranium, right? Head, so to say. So these are trigeminus, facialis, glossopharyngeus, vagus, and hypoglossus. This is glossopharyngeus. So it's a nerve that is giving the muscles information where to move, right? Or many nerves, right? I have so many nerves in there. So, and of course, physicians and medical experts will tell you more about this. I'm just providing a simple illustration of what can go wrong and what was the cause of dysarthria, which weakens your muscles, right? Muscles become weak and difficult to control in dysarthria. And in dysarthria, we have the causes of dysarthria can be strokes, of course, brain injuries, Parkinson's disease, and MS or multiple sclerosis, Huntington's disease, etc., etc. So all of these can lead to dysarthria, to the weakness of the muscles, and the signs and symptoms are, I would say, quite discernible, but it's still good to know about these. Slow and slurred speech. It can be also rapid speech that is difficult to understand because of talking nonsense, difficulty moving the tongue, abnormal speech rhythm, and so on and so forth. And finally, the treatments would be slowing down your speech, using more breath to speak louder, making your muscles stronger, moving lips and tongue more. And the treatment, of course, depends on cause and severity. For example, one of the tips is to say one word to establish a topic on conversation. For example, because of this difficulty of speaking and communicating, one needs to establish a topic on conversation. Let's say they want to talk about dinner, and they just say dinner, right? If that's not too difficult for them, then also breathing in, breathing out, right, as well can help. Knowing about respiration, and that's something that you learn in linguistics as well, in phonetics, especially advanced phonetics, about the respiratory cycles, how you can control them, is also very helpful for these individuals, because most of the time they can do this, right? So could control respirations, and it can help them have a better control of what they want to say, right? Even though their muscles are weakened, and making your muscles stronger is also very quite essential, if possible, of course, at least to some extent in the treatment. So dysarthria is maybe the first one that I will mention. I will mention just a couple. I'll go through these couple ones that are quite related to phonetics, to the articulation of speech. First, the example of dysarthria. This man has dysarthria and difficulty of speaking because of the weakness in the muscles.
Dysarthria is not a problem understanding speech, but of producing and forming the words because of weakness.
Can you tell me how long ago it was since you've had your stroke?
It's last September, had it, and then to hospital till Tuesday. I got out 2 days before Christmas. I got out of hospital, and that's me home after that.
So you were in about 3 months in hospital.
All right, yeah, this is the example of dysarthria. The second one is apraxia. Apraxia comes from a Greek word meaning which means without, and praxis, which means action, so without action. And this is a movement or motor disorder. However, it is not a muscle issue. It is not a muscle disorder. It is neurologically based. And apraxia is considered a disconnect and a difficulty of initiating volitional movement, right? So you have certain difficulty initiating and realizing this movement that you want to realize. The individual knows in their brain what the motor movement is, but they can't get the motor started to do the movement, so they can't get it to do what they want them to do, right? They definitely have it in their brain, so the conceptualization part is not a problem. Even I guess the encoding part is not a problem, but the planning and realization is the problem for apraxia. And after a lot of trials and errors, an individual might do something like this. For example, they might, as I said, after a lot of trials and errors, they might, without any issue, say the whole phrase, "Oh my God." But they would struggle to repeat this phrase. They will keep struggling if they want to find it intentionally. So this volitional part is also very important in apraxia. Apraxia, of course, indicates that the longer the word, the harder it is for individuals. And we have a research by Pollock and Hall, whereby 5 children, for example, aged 8.2 to 10.9 years old, they had developmental apraxia, and they had difficulty with the production of diphthongs, right? So they had huge difficulty with the production of sounds that combine 2 vowels. For example, they would reduce diphthongs and say instead of I, which is something that we as phoneticians are aware of, as we need to move, the tongue from a low position to a high position, right? Or a higher position right here. And then the tongue gets something like this, right? Okay. I. Also, the movement of the jaw is important in here, right? The jaw moves up as well. It becomes closed. So it's a difficult movement when you think about it, but we do it without any difficulty. So we are not aware of what we need to do. And as phoneticians and as speech learning pathologists, you are definitely or more than aware of what you need to do to make these or to make this diphthong in speech, such as bide, tide, and so on and so forth. Yeah, and that's something about apraxia. As I said, it's very important, again, to understand or to know these articulators and where they move, what is the target or what are the targets of these articulators, in order to be aware of what you need to do and how to treat how to diagnose and treat the disorder, right? That's where phonetics comes in. So now that you know about apraxia, you can compare it to aphasia, and we'll go through aphasia next. But I will just want to bring this to your attention, that apraxia is different from aphasia. Almost everyone with apraxia also has aphasia, at least that's what experts say, but not everyone with aphasia has apraxia. Because they can coexist, it makes the diagnosis and treatment challenging, right? Because sometimes you don't know what the patient has or what the individual is struggling with. Aphasia is like searching for a thing in your cramped and messy drawer, or searching for a piece of clothing in your wardrobe, or in my case, sometimes searching for my wife's eyeshadow in her bag, in her purse. So it's always a lot of things in there. Imagine a drawer as your brain, a lot of things, and you want to find something. You want to find a key, or you want to find a screwdriver, or whatever. You want to find something, and you might be successful after a lot of search. You might not, right? You might give up, and you might end up with the wrong thing. And this analogy should be applied to the word search, to vocabulary search. So you're searching for a right word, right phrase, right sound, in your brain, and you are practically going through the repository, going through what you can go through, and you might end up with a proper word, you might mistaken it with some other word, you might give up and not have a word at all. And that's aphasia, right? So that's I should write here like this, aphasia. It's different from apraxia because it is the intellect in both, I guess, is untouched, right? So the intellect remains the same, but apraxia of speech involves not being able to connect to the articulators and say what you want to say, and aphasia means that you are not able to find what you want to find in perception and in production. So there are different types of aphasia, which we will see in a second. And these two are often mistaken, right? And difficult to diagnose because they are very similar. But I hope I could bring closer to you this difference between the two terms of apraxia. These are different levels of apraxia, so some of them have more difficulties, some less.
Speech characteristics as he tries to repeat. Notice the inaccurate movements resulting in sound distortions.
Good job.
Yeah, you can hear here that this little guy couldn't produce a full diphthong.
Bye. Up.
Up.
Moo. Down.
And you can hear that the pathologist is, of course, exaggerating the sounds. There is a lot of repetition involved in the treatment, and exaggeration and enunciation of sounds. So that's very important.
Dad.
Dad.
Home.
Up.
Out.
Up.
Out.
Out.
Knee.
Knee.
No.
No.
Hi.
I.
Use your breath.
Hi.
Good. Mom.
Yeah, this is a good example of h sound and how the correction is being made.
Mom.
Mom.
Me.
Me.
My.
Bye.
Hi, Mom.
Hi, Mom.
Mom.
Yeah, these are bilabials, obviously, and some diphthongs as well.
My knee.
Not me.
Oh, no.
No. Oh, no.
Good job.
Yeah, so yeah, you can take a look at this video clip. It's quite informative. Aphasia is a language disorder caused by a damage in specific area of the brain that controls language expression and comprehension. The causes of aphasia are stroke, head injury, brain tumor, dementia, and there are two main types of aphasia: Broca's aphasia and Wernicke's aphasia, or two types that we are mostly concerned with. They are named by the damaged brain locations, and these two happen to be involved in speech production and perception. What is important to emphasize is that the aphasics do not have an impaired intellect, as I said in the previous slide. They are as smart as ever, but they have language production and perception issues. And we will now take a look at the Broca's aphasia. So all humans have two hemispheres, right? Or two brain hemispheres. And the one that controls certain language features is the left hemisphere. And how do we know this? Well, there was a scientist called Broca who in 1861 studied a patient who lost the ability to use almost all words. I think they could use a single word, and that was tan for some reason. During the post-mortem study of the patient's brain, in that period you had to wait for the person to die in order to study their brain. Today we have fMRIs and CT scans and CAT scans and whatnot that allow us to explore the brain functions in real time. So Paul Broca did a post-mortem study of the patient's brain, and what he discovered was a large lesion, something like here, right, in the brain. And this lesion was in the left part of the hemisphere, now known as Broca's area, of course, named by Paul Broca. Scientists today believe that Broca's area is responsible for, in part, of course, for naming objects and coordination of speech gestures, or gestures needed for speech. So this is also a neurological condition or a lesion, so to say, which prevents speakers from articulating what they want to articulate, right? There is a disconnect in a way, but not a disconnect between the articulators and neurons, or between the nerves in the face and let's say brain. So patients with Broca's aphasia often have challenges finding the proper word and producing it, uttering it. This is a state which is also called like the aphasia of production and of production of words. I'll stop there, and I'll try to show you in a video clip what this looks like. Broca's aphasia. So this is an example of Broca's aphasia.
Now tell me what this thing was with your legs last week or week before.
No good. Ache and
yeah, they're struggling obviously with finding proper words, so they're trying maybe the technique of single word, I think ache, and those modifiers are very difficult to find, like yeah, in this case it's just a connector and, but in general modifiers such as the my, your, and so on and so forth are difficult.
Knees and ankles.
What'd you do about it?
Home.
Yeah. Just behind the Broca's area, there is another area near the auditory cortex called Wernicke's area. Wernicke's area is responsible for language comprehension, and that's where the brain attaches meaning to speech sounds. Damages to Wernicke's area impair the patient's ability to comprehend language. So it's about comprehension usually of the language, and not so much of production, although later it was discovered that this comprehension influences production as well. It is believed that Wernicke's aphasics can produce a lot of things, a lot of sentences, utterances that are nonsensical in a way, but they struggle to comprehend language, right? They struggle with this comprehension side, with this perception of the meaning of language. And this Wernicke's area was named after Carl Wernicke, a scientist that was a bit older than Paul Broca, but he discovered this disorder in patients with lesions in this area. It's aphasia.
They're afraid, boom.
What's this?
The big end right there. All right. End of the football.
End of the football?
Is it influence the football right here? The cause that it comes in, see?
Yeah.
The end of it, see? Yeah. Oh, we have all of these, see?
I don't understand.
Well, it's pliable in the other, see? You don't understand it, but it plies in the long reed comes from there, and it comes source from the country out through it, see? All the under it, see, it comes up, and finally come out here and goes out, see?
Yeah, because this person has a problem with comprehending certain parts of speech and or just struggling with the meaning of speech. They are struggling with communicating their message to the interlocutor. And so that's also part of Wernicke's aphasia. So how common is aphasia? Well, around 1 million people in the USA are diagnosed with aphasia. And 1/3 of stroke survivors also are diagnosed with aphasia, which is more prominent than multiple sclerosis and some other diseases such as Huntington's disease. Although very few people, not very few, but fewer people know about aphasia, and we need to raise awareness of what it means. Obviously, language improvement can be achieved through speech therapy, and luckily, quote-unquote luckily, other parts of brain take over some functions. This is the ability of brain which we call brain plasticity. So brain is able to adapt to these circumstances. Some parts of the brain take over some functions in this recovery process. And SLP experts and neurologists together are trying all sorts of mechanisms to treat aphasia, to encourage this brain plasticity. So you cannot, in a way, you cannot build another Broca's area, or you cannot put in another person's Broca's area, not that I know of, into this part of the brain, and then there you go. There you have it. No, you have to actually train people into the ways of encouraging the brain plasticity, or other parts of the brain taking over these functions. And yeah, there are some kinds of treatments called transcranial direct current stimulation, transcranial magnetic stimulation. You can read more about those on your own, but essentially they put some kind of they use magnetic fields to stimulate your brain while you're doing something. And that's all I'm going to say about it. You can explore these in your own time, right? And we've come to the morals of the story number 2, and something I would like to conclude this short lecture with. There are certain crucial types of knowledge every SLP expert needs to have. First one is the knowledge in phonetics, or at least articulatory and acoustic phonetics, but also perceptual phonetics. There are so many perceptual disorders that you have out there. So it's good to know at least some fragment of phonetics, how to produce speech sounds, how to analyze speech, how to perceive speech, what mechanisms individuals use, or normally developing individuals and those with disorder or challenges, or those with challenges, what mechanisms they use and compare, right, in order to be able to diagnose and treat these challenges that we mentioned, this Dysarthria, Apraxia, and Broca's and Wernicke's aphasia. So we just mentioned a couple, but it's the knowledge of phonetics is crucial. The knowledge of the types of disorders, we went through 4 of them, right, is also basics for understanding problems. And psychological consequences such as isolation and depression. Most of the time, these patients and individuals suffering from these disorders or challenges are isolated, they are depressed, and that's very, very serious. So we have to know how to diagnose, how to treat them, and how to support them and encourage them in their endeavor to communicate like we all do. Thank you for listening, and hope you found this lesson quite useful and informative.